Wonderful. Well, thank you for joining. Good afternoon, evening, good morning, depending on where it is you're joining us from the world. Hello, my name is Dr. Ananda Amstadter. I'm the president of the International Society of Traumatic Stress Studies, and I'll serve as the moderator for today's webinar. As the premier global traumatic stress society, ISTSS has an important role in educating and raising awareness about the consequences of traumatic events, such as the wars in Ukraine. Today, we will hear from 3 trauma professionals and ISTSS members about opportunities and challenges for traumatic stress professionals affected by the war in Ukraine. Before I introduce our experts, I'd like to share a few announcements and technical reminders. We will be recording today's session, which will be available on the ISTSS website within a few days. We'll be promoting that on social media when that's available. We also have included a list of resources related to the war in Ukraine on the ISTSS website, and we'll provide a link to our website and those resources in the chat box shortly. Finally, we welcome you to submit questions for our speakers throughout the session using the Q&A box in Zoom. We'll leave plenty of time, about 30 minutes at the end of today's session of the webinar for our panelists to respond to your questions, and we'll do our best to get to as many questions as possible. So without further ado, I would love to introduce today's speakers. We have Dr. Arina Frankova, who is a clinical psychologist and assistant professor in the Department of Medical Psychology, Psychosomatic Medicine, and Psychotherapy at Bogomolets National Medical University in Kyiv, Ukraine. She was a co-director of the advanced workshop entitled Risk Management of Terrorism and Induced Stress, Guidelines for the Golden Hours, Who, What, and When, in Odessa, Ukraine, which is supported by NATO Science for Peace and Security program. Currently, Dr. Frankova serves as the chair of the Traumatic Stress Network for the European College of Neuropsychopharmacology. We are also joined by Dr. Marit, who is a professor of clinical psychology in the Department of Clinical, Neuro, and Developmental Psychology at Vrije University in Amsterdam, the Netherlands, and the director of the WHO Collaborating Center at VU University. Her research areas are prevention, early interventions, and public mental health interventions for post-traumatic stress disorder and other mental health problems in populations exposed to trauma and adversities, including refugee populations in low and middle income countries. Marit is also the president-elect of ISTSS. And we are also joined by Dr. Pieter Ventevogel, who is a psychiatrist and a medical anthropologist. He serves as Senior Mental Health and Psychosocial Support Officer with UNHCR, the Refugee Agency of the United Nations. In this role, he supports country operations of UNHCR with technical guidance around mental health and psychosocial support for refugees and other forcibly displaced populations. We're delighted to have these experts with us today, and I'd love to turn it over now to Dr. Frankova to begin our presentations. Thank you.
Thank you for a kind introduction, and definitely I'm honored to be here today, and let me share my insight from lessons, what we've learned so far from war in Ukraine. So you see those pictures and there's something common. Those people are Ukrainians. However, those people are in a different emotional states and probably different mental states. So far here, you can see people hiding in a metro station, in shelters, or waiting for green corridors to escape from invasion. And as well, they're leaving like hospitals, or in this case, maternity hospital, which was just bombed. In this part, you can see people fleeing war by car or by evacuation train. And as well, something which is so common these days is a separation of women with children and husbands, the fathers and brothers, because men are not allowed to leave our country. Those people are standing in lines next to the border, and finally they find shelters in Europe, and at least they can sleep safely, which is like something that is lacking when you're still in Ukraine. And when we talk about war stress, we can think about something common for those people, and they experience, and when I say they as well, I mean myself, of course, that we face inescapable life change, just unexpected, and losses of many types. And those are not just physical losses, but as well symbolical losses of future plans, of imagine of oneself or about the world, of course. We face uncertainty, like where to go, where to find food, where to live, what might happen, unpredictability, and of course, a huge exposure to death scenes and destructions, or either as like ourselves or through media and social media. And probably that's something not just Ukrainians experience, but the world as well. So it's more than a month has passed since the war, and it is a question like, would you treat PTSD or other mental health consequences of war stress if person is still hiding in a shelter or experiencing daily bombing and lack food, lack water, or isolated? And the answer is clear right now for me, but it was not clear before war has started, that psychological aid under war stress is not something the same that should be applied after exposure to stress when people are in secure environment. This is very important, and that's why I'm thinking about targeted population sensitive approach. When you see people and those who are like in those cities next to the Russian border, they still are insecure and each day face and exposed to traumatic experience. Those who flee from western part to eastern part, it's so-called security, but like several days ago, a major city next to Poland were bombed, Lviv or other cities are still attacked, but we know that about 250,000 people were internally displaced, and of course many more. Those were in yellow. Those are forcibly displaced people, and their condition is quite different. So when we talk about those who are unsafe. So first of all, they lack resources. So the problem is the main logistic hub was Kyiv. Right now, it's not. So all the supplies and logistics should be modified. So the ways how we transport medication, food, water, and so on is now under reconstruction or rebuilding. And of course, those people, first of all, in need of optimization of survival, which is, of course, not treatment of some stress reactions, but is a help in adjustment to the current environment. And we should take into account not just their needs, but the capacity of the environment. So we're lacking medication, so hospitals are more equipped with medication, but outpatients, so like pharmacies, they still lack just regular treatment like insulin or treatment for thyroid gland and so on, not talking about mental health and psychotropic drugs. When we talk about internally displaced people, so they still might lack resources because like this part of Ukraine is overwhelmed with people. They need to find place to stay, employment probably, and medication as well. But we see right now some kind of services for internally displaced people, for example, psychologists and psychiatrists, they stay around the clock at the railway station where evacuation trains arrive, trying to identify those who are at acute stress, those who face some acute reactions, and provide them first psychological aid directly at those railway stations while people waiting for buses and keep trying to sleep at least for one night before they will plan to go abroad. So, and this is something about the hope, is that the majority, of course, will feel themselves better and will feel this spontaneous recovery process when they will be in safety. And we're talking about 80 to 90% during the next months. They will just recover or even stay resistant. And the minor part, of course, might face some mental health issues, and they are a target population of mental health systems outside Ukraine. So in Europe and in US, in Canada, and those countries who support forcibly displaced people from Ukraine. And their needs are networks, and because we need to activate the attachment bonds. And of course, social media plays a huge role, because you would find probably in each country a Facebook group like Ukrainians in the Netherlands, or Ukrainians in Poland, or in Romania, or in US, and we see each day people supporting each other within those networks. And still, those people need optimization of their processes like safety, routines, and so on and so on. And what, like, the main lesson we've learned so far is that we won't be able to assist a huge number of people that was forcibly displaced with in-person help and system. But something we can do is to deliver aid through digital tools to Ukrainian population. For example, first psychological aid, or other things we have. And what is needed, of course, is to help people to control their emotions, because there are a lot of reactions these days, and not just fear or panic. It's as well a grief and separation reactions and anger. Of course, it's very important to maintain positive view on what is happening and what we stand for. And we see that media is a kind of battlefield as well. And some news, unfortunately, they work in the opposite direction. And capacity to maintain meaningful context is, of course, of help in any place of the world. So I would like to tell you some information about what have been done so far with colleagues from as well International Society of Traumatic Stress Research. And this photo was made 4 years ago. It's Odessa, Ukrainian city, and you can see probably familiar faces of Marit here, Arik Shalev, and Simon Wesley, and Professor Joseph Zohar, and Stephen Hopful. So we were, and Kerry Ressler, so many you would, and Robert Ursano, so you would probably know many of them. And we were sitting all together 3 days in Odessa, and we were thinking like what kind of recommendations and guidance we may develop on what to do, and as well on what not to do right after a terror attack. And as the result, we have a book published, supported by NATO Science for Peace and Security program. And moreover, we were able to create a mobile application with short and doable instructions, which is available both on Google Play and App Store. And those instructions, which I think is very important, were structured according to scientific traits. So we have a color code with green recommendations, which are positive empirical evidence, with yellow recommendations, which is our clinical knowledge and something that we know from the ground, and red instructions colored in red color, something that is not recommended because we know that it's harmful. And the first thing to remember, we should keep in our mind that we should not do harm to people exposed to traumatic events. And unfortunately, there are something that might do so. As well, we have a 3 dimensions or kind of metrics. So we have a timeline and specific recommendations divided for first 6 hours, first day, first week, and something that is recommended or not within 1 month. We have individual recommendations and group and community recommendations, especially for media and social media coverage. Something as well should not be done when somebody is posting a news in a newspaper or Facebook. And we have a third dimension, which is population. We have recommendations for adults, for children, and military and first responders. But actually, this was something that was done already before war has started. And what we face now is that we lack dimension under stress, a timeline under stress. And so we have this clear idea that something should be done like within the first months, but what are recommendations when people are still exposed or like during traumatic experience? And this is something to discuss with the scientific community. For example, what is not recommended during ongoing traumatic experience. And there are debates within the mental health community in Ukraine, whether or not prescribe benzo, whether or not use debriefing, whether or not to recommend people a group support, which might be, of course, emotional talk about what have happened. And there are still a space for a discussion in this topic. And least but not the last, what we were able to do is to translate those recommendations from the guideline into recommendations for civil population. I mean, Ukrainians. So we were able to launch a chatbot, which has those instructions in a friendly tone delivered to people through a Telegram messenger. And we have different scripts for those people who are under stress and those who feel themselves more or less safely. We have recommendations for parents with children in shelters or on how to use mindfulness techniques or some muscle relaxation. And because it was as well based on WHO recommendations, and first psychological aid. And so far 1 month has passed, and we are preparing another portion of recommendations sensitive to those emotional responses those people have. And the good news is that this chatbot is already widely used, so it has been activated for 40,000 times already. And so far this is all I wanted to share with you. Again, thank you for invitation, and I would be glad to answer your questions. Either you can address them through my email. Thank you.
Thank you, Dr. Frankova. Marit, we would love to hear from you next.
Thanks, Ananda. So I'll share my screen. Yes. Okay. So thanks a lot. I'm very honored to be invited to this important webinar, so rapidly organized and professionally organized by ISTSS. And I'm also honored to present after Iryna, who just talked also as a first with her own experience, also her stories from Ukraine and her experiences with developing psychosocial interventions. I will talk about mental health symptoms among mainly refugees and migrants, because that's what I'm mostly specialized in. So not so much about people who are currently in Ukraine still, although some of them may also be relevant for that group. And will also talk about evidence-based psychosocial interventions for populations affected by crisis and war. So as Iryna already explained very well, of course, Ukrainian refugees and people currently having to flee or having to seek shelter for the war in Ukraine are affected by many types of traumatic events and life stressors. First of all, there's the war itself. People have to seek shelter to be safe. They have to leave their country, sometimes in a very dangerous way. They have to go through a corridor. They're seeing people dying around them, having family members also passing away. Sometimes people lack shelter and food. Currently, of course, we've all seen all this terrible news from the southern cities of Ukraine. People have to leave their family behind, specifically males. Of course, females can leave the country, but males, because of having to be there to be part of armed forces, or they have vital jobs, they need to continue, they have to stay. And of course, once they come into a safe place, they can be facing overcrowded reception facilities. People are sometimes very isolated. They have to leave their surroundings which are very familiar to them, and suddenly they have to go to an entirely different country with a different culture, different people around them, different structure, different system. And it's difficult in a new country to find a job. And being unemployed, specifically when you were employed in your country and you had a good job, actually can lead to a feeling, a loss of role and a failure of migration expectations. Sometimes people have to face long uncertainties regarding whether or not they can stay in the country they are now resettled. In the country where I live, in the Netherlands, actually, and in European countries, Ukrainian refugees are given quite quickly residency permits for a limited period of time. But of course, it's yet unclear what happens afterwards. And it's also important to realize that other refugees coming from other areas do not have these specific circumstances, unfortunately. People are often also worrying about the situation in the country where they come from and about their safety of their family members. So for these reasons, it's very clear that people who are exposed to war, who are in a humanitarian crisis, or who are leaving and externally displaced from their country are at an increased risk for mental health problems. And we recently did a systematic review, a meta-analysis by a colleague from Italy. And we found in this meta-analysis that, and this was a study in which we included only studies with representative samples that conducted clinical interviews to make diagnosis. We found a rate of 27% of people having major depression or meeting the criteria for major depression, 24% for PTSD, 6% for bipolar disorder, and 1% for psychotic disorder. And although these percentages for the most severe and serious disorders like bipolar disorders and psychotic disorder are not so high, it's much, much higher, like 10 times and 4 times higher than we find in the general population, where the prevalences are all under 5%. And of course, this leads to a lot of other problems as well. In addition to the suffering caused by the disorder, it also leads to impaired functioning and related somatic health conditions. It's also important to say that these percentages are averages, but we also found a very big variation between studies. So how can we best assist the people who are in need of mental health services following trauma and following crisis? Of course, this is a well-known pyramid that has been published by the Interagency Standing Committee. It's often used in humanitarian settings, and I think it's still very relevant also to the Ukrainian crisis. In the level on the bottom, you see the most basic type of support we have to offer to people affected by war. And these are the basic services and security. Of course, main thing is that people are safe. They have access to the most important things like medication, what Iryna also said. And they have to be protected from further harm and having food. One layer up, we go to the community and family supports, which is quite basic psychosocial supports offered to entire communities or to families, not necessarily selected for psychological distress. A type of intervention that is very well known in the trauma field, actually also originates from the PTSD field, is psychological first aid that was developed by the Child Traumatic Stress Network, and that has also been adapted by WHO. I will tell about that later. One layer up, we go. There is the focused person-to-person non-specialized supports, and these are types of interventions that we would offer to people with high levels of distress, for example, but not necessarily people meeting criteria for a disorder like PTSD or depression. So examples of these types of interventions are the quite low-intensity types of interventions, such as Self-Help Plus, which is mainly a preventive intervention developed by WHO, Problem Management Plus, which is a more curative intervention for people with increased distress, transdiagnostic. And also another very well-known intervention is the Common Elements Treatment Approach, or CETA. And of course, there are many more interventions to mention here, also interventions with evidence, but I will flag mainly the ones that we studied ourselves. And in the top, we see the specialized services, which are the services that are also recommended in the guidelines. For instance, the guidelines that ISTSS has published on PTSD, but also guidelines on depression. And the interventions we're then referring to are, for instance, CBT, EMDR, cognitive processing therapy, or specifically for refugees or people in low and middle income countries, there's narrative exposure therapy, also with very good evidence base. In terms of very basic intervention, psychosocial intervention, there is the manual psychological first aid that has also been published by WHO. It basically consists of practical care and support to address basic needs and to help people to be protected from further harm. It's meant to focus mainly on linking people to information, to services they can access, basic services, but also social services and social supports. So how people can actually access people in their immediate surroundings. It is also based on what Iryna also flagged, the negative experiences, or also a lack of evidence for psychological debriefing, that there is no specific emphasis on having people express emotions related to the traumatic event or pressure people to talk about details regarding the traumatic event, but it's more focused on listening without pressuring and reducing symptoms of distress by comforting people. And it's trained in humanitarian settings worldwide. Unfortunately, until very recent, there has hardly been done any studies on PFA. We did a study together with Queen Mary's University in Scotland and ARC International in Sierra Leone, where we trained people in psychological first aid. These were people that were practitioners or medical staff in healthcare facilities across the country. And we did a randomized controlled trial. We randomized people who were trained facilities and facilities that were trained at a later stage in time. And we found that after a half a day of training, the people who were trained in PFA actually showed an improved knowledge of adequate psychosocial responses to acute adverse events. We actually gave them a kind of an exam. We asked them open-ended questions. How would you respond to people if they would come into your facility and they would need psychosocial support? And that effect remained up to 6 months after the training. But of course, the most important thing is how do people respond when they have been receiving PFA? And fortunately, a study has been published recently, a study done in the US in assault victims, showing that a PFA among assault victims actually showed no direct effect on mental health symptoms. However, there were some indications for a faster recovery of general functioning in the people who received PFA, which is in fact reassuring because previously we had some negative results of early interventions, and this is actually indicating no harmful effect or potentially a positive effect. Another intervention that I think could be interesting also in the context of the Ukrainian situation, but for refugees in general, is Self-Help Plus. Self-Help Plus is a 5 sessions group stress management course developed by WHO. It's meant to be delivered. It's very scalable. It's very easy to deliver because it can be delivered to groups up to 30 people that are guided by non-specialist facilitators with minimal training. And the intervention consists of teaching people relaxation exercises, mindfulness and compassion. So it's based on acceptance and commitment therapy. There's an illustrated book on Self-Help Plus. And also it contains, there's pre-recorded audio exercises that can just be accessed on the internet. And I've provided here the link. There's also a Ukrainian and Russian version. It's effective in, and we did RCTs on the effects of Self-Help Plus, and it has been shown to be effective in preventing the onset, the new onset of mental disorders in refugees in Turkey and in Europe, and also in reducing distress and improving well-being in refugees in Uganda. And you see here a picture of the study in Uganda. And another intervention that has been developed also by WHO that we have been studying also at our university is a Problem Management Plus. Actually, it's quite widely spread at the moment. Also, for instance, in the US now, Problem Management Plus is implemented also in the South American countries, but also in other countries worldwide. It's based on task sharing, meaning that it can be delivered by non-professional helpers who are trained by psychotherapists or psychiatrists, so mental health specialists, and also receive weekly supervision of these specialists. Like Self-Help Plus, it's very scalable. We also know from randomized controlled trials that it's effective. And what is also important is to mention is transdiagnostic. So it's not necessarily meant to treat only PTSD or depression or a specific anxiety disorder, but people can actually be offered PM Plus when they have any type of these common mental health problems. So they just have to do a screening instrument, for instance, the K10, and then when they score above the cutoff, they can enter. It's very short. It consists of 5 sessions of 90 minutes. And in the Netherlands, we even reduced the number of minutes in the session. So we went until 60 minutes. We have to see still whether it's still effective. We're currently evaluating that. There's an individual version, but there's also a group version for groups from 8 to 10 people. And of course, it's always important to do some cultural adaptation to the target population before using it. It's not meant to delete the effective components of the intervention, but more to adapt the ways, the language of the intervention, and to make sure that it's acceptable to people from a specific cultural background. There's also a Ukrainian version. So the aims are to provide participants with skills to manage emotional problems related to depression, anxiety, and stress, as well as mainly daily practical problems. And that could be any problem, such as a problem as I can't, I don't want to bring my child to school because I'm afraid of going outside, or I feel very lonely, and it can be any daily practical problem. And the content of the intervention is focusing on problem-solving therapy. It's stress management, so reducing distress by relaxation exercises, behavioral activation to get more active again, which is a very effective component of depression interventions, and accessing social support. In terms of the evidence, we did the first studies on PM+ were actually done in low-income countries. They were done in Pakistan, in a Peshawar area, an area affected by a lot of terrorist attacks, unfortunately. We found that PM+ was significantly more effective in reducing depression, anxiety, but also PTSD, which is remarkable because it's not a trauma-focused intervention, but still. And we also did a study in Kenya, in an urban slum area in Nairobi, where it was also effective in reducing depression and improving overall functioning. Group PM+ version was effective in Pakistan as well, in the Swat area of Pakistan, and also in Nepal and in Jordan. And Jordan is particularly relevant because it's a study in refugees. Here you see an overview of the study we did in the Netherlands on individual PM+. We evaluated it in Rotterdam, a city, the second city of the Netherlands. And we found that PM+ individual was effectively reducing anxiety, depression, and PTSD, both at 1 week and at 3 months after delivering it, compared to control. And also in reducing these self-identified problems and improving functioning. And currently, we're finalizing a much larger randomized controlled trial among Syrian refugees, also in the Netherlands. In Jordan, we also evaluated the group version of PM+ in a refugee camp, Azraq refugee camp. This was done by the group of Richard Bryant from the University of New South Wales, together with the International Medical Corps, a large NGO. And they also found significant reductions in depression and self-identified problems, but no reductions in anxiety, PTSD, grief, disability, or the mental health of the children of the people who were receiving PM+. After controlling for ongoing stressors and traumatic events, actually the effect went up. So we had a stronger effect on depression symptoms that actually suggests that experiencing ongoing stress does reduce the effectiveness of an intervention such as PM+. In terms, finally, of indicated prevention strategies, if we look at the guidelines for that were published by ISTSS, what do we know that is effective in terms of treatments for PTSD? We know that stepped care strategies, collaborative care strategies, where, for instance, early after the trauma, an early intervention or an evidence-based brief version of CBT is offered, but then when people need more than that, they can step up to a higher intensity intervention, could be effective. Indeed, we did find that it's quite established that brief cognitive behavioral therapies, for instance, from 4 to 6 sessions, are effective early after the trauma, for instance, 1 month to 3 months in the acute phase of PTSD. And the same evidence has been found for, or almost the same for EMDR, eye movement desensitization and reprocessing. So concluding, we do have some evidence for scalable interventions for war and crisis-affected populations. This has mounted greatly during the past 5 years. Interestingly enough, most of the evidence comes from low and middle-income countries. But of course, it's also relevant for high-income countries, such as the European countries or the US, currently also facing huge numbers of refugees entering. It's important to emphasize again that cultural adaptation of intervention to target populations is always needed also because we know they're more effective. There have been done some direct comparisons or a meta-analysis comparing adapted interventions versus non-adapted interventions, showing better results for the adapted interventions. And it's of course important to always offer interventions in a multi-sectoral way. So not only focusing on one problem, for instance, on PTSD, but also addressing multiple problems, multiple levels in the community and multiple concerns that people have all at the same time. And in terms of new research venues, I think Iryna also nicely talked about that already. I think we can do a great deal with digital innovations and also to develop interventions that could be potentially effective for people suffering from ongoing traumatic events or being under current threat. So thanks a lot for your attention, and please do contact me if you are interested in more information.
Thank you so much, Dr. Sijbrandij. And next we have Dr. Ventevogel.
Thank you very much. Let me see if I can share my screen already. Yes, I can. Thank you very much for inviting me. What I will do is I will share some insights from the practice of humanitarian work. Can you see my screen at the moment?
Looks great.
Yeah, okay, great. So I'm working with UNHCR, the United Nations Refugee Agency, and well, one of our major projects, major situations now is, of course, the Ukraine. We have almost 4 million Ukrainian refugees. I guess tomorrow we will pass the 4 million border marking point. And that is really, really much more than we ever envisioned. When we planned for figures about a month ago, the most pessimistic estimation was that we could reach up to 4 million refugees by the end of June. And actually, we're almost there now. You see the figures here. Most people are still in the east of Europe, but significant numbers have moved on, but we do not really know exactly where they are because most of the countries are in the Schengen area, so there is free population movement, so it's not possible to track. But these are unprecedented numbers. And on top of the 4 million refugees that I'm mainly focusing on, there are also around 6 million internally displaced people in the Ukraine. So we talk about 10 million forcibly displaced people within a month, which is really enormous. So this has led to a major response plan. Now, the major actors there are the national governments in case of refugee situations and the government of Ukraine when it comes to the internally displaced populations. This is important to emphasize because whatever humanitarian agencies like mine or volunteer groups do should be supporting the national responses. In order to do that, there are two major UN-led plans. One is the regional refugee response plan. It's coordinated by UNHCR, and the other one is the humanitarian response plan for Ukraine, led by UN-OCHA, United Nations Office for the Coordination of Humanitarian Affairs. Now, in these documents, and that's the good part about it, in these documents, from the beginning on, mental health has been mentioned. It's been high on the priority list. What you see in the yellow highlight here is if you see at the major urgent needs described in the regional refugee response plan, the first thing that is mentioned is the need to strengthen access to mental health and psychosocial support. So, and there is, of course, a clear reason why that is so, because mental health issues are very visible in this current crisis. Many issues around food and shelter are relatively okay compared to other situations where we usually work in, but the vulnerability for mental health issues is really very high. There are some groups that are at high risk, women and girls, and as Iryna already said, most of the refugees are actually women, girls, and children, because men stay behind in Ukraine to defend the country. Now, this gives a very atypical refugee population, very high numbers of female-headed households, or single women, single girls, with really high risks for gender-based violence and abuse. Gender-based violence can, of course, happen before displacement, during the war, but also during the displacement, and this is something we really need to be very vigilant for. Trafficking risks are on the rise, but also risks for sexual exploitation and abuse by people who are there to help. We've seen incidents like this happening in the informal centers, in reception centers, transit facilities, etc. And also sometimes inadvertently by volunteer groups who help but may not always have been vetted or have limited experience on how to react, and sometimes inadvertently make things worse. Similarly for children, problematic still is that there is not a comprehensive cross-country registration system for child protection issues. So those are really issues that we are working on now to develop. Particular vulnerabilities are for children with pre-existing problems, pre-existing psychosocial, developmental, or intellectual disabilities. We hear the stories, unfortunately, of children with severe behavioral issues, intellectual disabilities, who are extremely distressed and sometimes in the care of parents who are not able to provide the support the kid needs, and those are very difficult situations. There are also children in institutions in Ukraine. Some of them have been moved already to Poland. Similarly, but that's not for children, people living in institutions, psychiatric institutions. There are still around 30,000 people living in long-stay mental hospitals in Ukraine, and those people are extremely vulnerable for neglect and abuse. So this should also be high on our radar. So the issues are many, very many. What are we doing to help? Well, the first thing I want to highlight is that within humanitarian mental health, and that's how I define my field in humanitarian mental health care, we use the term MHPSS, and Marit also referred to that, which is a very broad concept. It's not only the clinical issues that need treatment, but also issues around psychosocial well-being and how to strengthen psychosocial well-being through interventions within families or within environments. Now, what kind of issues do we expect? And I think Iryna mentioned this very clearly in her very powerful and moving presentation in the beginning. First of all, very high levels of distress. Many people are anxious or worried and who are grieving. I think grief is still to some extent undervalued as an issue in forcibly displaced populations. I've seen many refugees who are not psychologically traumatized in the clinical sense, but I've actually never met refugees who are not grieving over what they've lost. And that's a very acute and real issue. And how can we help people in grieving, in bereavement? Of course, some, well, more than some, quite a lot will develop common mental disorders such as depression, PTSD, and anxiety disorders. And some others will have severe mental disorders. And I want to highlight that. There are not very hard data on that, but what I see consistently when I go to refugee settings is that people with severe mental disorders, bipolar disorders, schizophrenia, long-term psychosis, are first of all extremely vulnerable, but I also think the prevalence is higher because of the protective factors that may have kept them stable are breaking apart. And lastly, let's not forget substance use issues, which we also know in humanitarian settings actually may be on the increase because people may resort to substance use as a coping mechanism. Now, in humanitarian work, we use slightly different figures than Marit just presented. These are based on an estimation by the WHO of people living in conflict-affected areas. And figures Marit presented were from refugees who are displaced to other countries. But the ballpark figure here is 22%, 1 in 5 have a clinically significant mental health condition, and 5%, 1 in 20, have a severe form of that. Well, those are enormous numbers if we talk about 4 million refugees now in Europe. So the needs are enormous. Before I go to the response, I want to say a bit about the role of daily stress factors, and I think that was also mentioned already by both Iryna and by Marit, but I think it's really important to highlight there is not a linear, or let's say not just a linear relation between armed conflict and individual mental health conditions. This is mediated, first of all, by the microcosmos where a person lives in, the family, the mental health of the parents in case of children, but also by displacement-related stressors. And you see a whole list here. Those are important because if we address them well, we actually also improve mental health by giving people safety, by giving people access to education, to job, to healthcare. We actually minimize the risks that people develop mental health problems. Now, a bit about the response. What should we do and what should we not do? First, a slide about what I think we should not do. And we've learned that the hard way. In the past, we've seen how MHPSS programs assumed that everyone was traumatized and everyone would need counseling or psychological therapies. It would focus only on traumatic events instead of on the social stressors that actually may worsen or even cause mental health issues. Or that too much resources went to screening and identification without commensurate service delivery. Or in general, and that's really something I've learned in working with low-income settings, we may tend as professionals to use a service delivery model where we provide services for people instead of working with forcibly displaced populations. And as you will see in the next slides, there are lots of strengths within refugee communities that we can utilize in making the mental health of the population better. I will go very quickly. There are several guidelines and handbooks. This is the major one for humanitarian work, the Sphere handbook. I will not go too deep into it, but if you want to check it, you can find it online. The one that we mostly use is the one Marit already presented, the ISTSS guidelines, which are also the basis of the document you see on the bottom, our own UNHCR documents. So this is really, this pyramid is really kind of the icon of humanitarian MHPSS, and whether you work with an NGO, with UNICEF, with the World Health Organization, this is the model that we use, which has greatly helped in working towards collaborative approaches. Now, you see 4 layers. Marit explained them. I will illustrate them. Start with the bottom, these social considerations within anything that we do. In UNHCR, we tend to call that using an MHPSS approach. We make a distinction between MHPSS interventions, things you do with the explicit goal to improve mental health. It could be counseling, could be medication. But we also have an MHPSS approach, which is not so much of doing something specifically to improve mental health, but doing your thing, whatever that is, shelter, cash assistance, registration, in a way that is conducive for mental health. Now, how does that work in practice? Well, one way is make sure that people have the right information. Information is one of the first and foremost important anxiety-reducing measures that we can have in an emergency. there is a little bit of a problem here because there are very many information tools now. So there is a kind of infobesitas almost in the humanitarian response. We try to somehow link things. This is an information leaflet developed by the University of Oxford. But as you see on the logos below, it has been endorsed by World Health Organization, by UNICEF, by UNHCR and different NGOs. So it's important to come to a certain consistent messaging for people. And I showed you the English version, but obviously it's available in Ukrainian and also in the languages of the hosting countries. And also part of this basic response is training people in how to react to other people who are in distress. That's for me the simple way of defining psychological first aid. So it's really a skill for all first responders. And so this is really a major target now to help people in the humanitarian response, including the volunteers, to train them in PFA. And as you see, the tools were already available in Ukrainian because they had a war in the Donbass for years. So the documents are there, adapted documents, and also the trainers are available. Let's now move to this second layer that Marit described, strengthening what people can do themselves. Here you can think of organizing trainings or courses in parenting skills, or providing spaces for women and children where they're safe. Or, not now yet, but probably slightly later in the emergency, training people, volunteers from the refugee and host community who can then help others and then can identify people who need more support, or could even be trained in interventions such as Self-Help Plus that Marit talked about. But as I said, the response is overwhelming, and overwhelming is not always good in the sense that there are so many people who are willing to help. Sometimes refugees don't know where to go in the jungle of logos and flags. And so in order to somehow mitigate that risk, UNICEF and UNHCR are establishing what we call blue dots, which are logo-less spaces. Everyone is welcome to support, but not with all your logos on flags. It's just a blue dot is the logo. And there you can find, sorry for moving my slides too fast. There you have one place, a safe space, where you have a minimum set of predictable interventions, which could be related to information. As I said, information really is key, but also to psychosocial support, having a safe space for children where you can also identify which kids are really not coping and may need more care. We will have around 25 of those blue dots in the refugee hosting countries in the East, and many are already operational. Now, the next step are these psychological interventions, people who need more targeted support. And I won't say much about it. We have Problem Management Plus. We also have a version of this Self-Help Plus that Marit mentioned, but then developed as a standalone self-help book. It's called Doing What Matters in Times of Stress. And the good thing is they're all adapted linguistically and contextually for the Ukrainian context. And more than that, we have the trainers. One of the main trainers in Doing What Matters in Times of Stress is now the mental health coordinator of WHO in Moldova. And someone who was involved in Problem Management Plus is now working with UNHCR as the mental health and psychosocial support coordinator in Poland. So we really hope we can roll this out quickly, but it needs, of course, additional attention and support. Lastly, clinical mental health care. Now, here, really the goal is not to develop parallel services, because we are in high-income countries here. So the goal is really to ensure access of Ukrainians to the system. And Poland and the neighboring countries have admirably opened all their services, all their health services for Ukrainians. But doing that does not automatically mean that people also get the care they need. So what we now need to do is make sure that people are referred in a proper way, that there are people who can help them with translation if needed, and that people know to find the way. Another issue is actually a breakthrough is the Polish government has allowed Ukrainian health workers to work in their health system, and that includes mental health professionals, including psychologists. Also, the Polish and the Moldovan government have agreed that prescriptions from Ukraine for the moment will be acceptable in pharmacies in these countries. And those are major steps actually in providing support for Ukrainian refugees. As you can imagine, there is a need to coordinate all the actors who are willing to help. And I want to show you where mental health and psychosocial support sits. This is an example of coordination in Poland, really with the government of Poland in the lead, having the co-chairing role in a refugee coordination forum. And under that, you have the sectoral responses. Now, where would you put mental health? Well, that depends a bit on where you come from. Some people would say it's under health, others say no, it's under protection. Some people even say no, do it under education because there are so many children. Well, what we say is you need to have an intersectoral working group, and that's what you see in the middle, an intersectoral working group for mental health and psychosocial support. Now, the last, can I have 1 more minute, Amanda? I don't hear a no, so I
yes,
take
please
it
go
as
on.
a yes. I take it as a yes. One very interesting document is a toolkit with key resources around mental health and psychosocial support in Ukrainian, but also in Russian, in Polish, and Hungarian that you can find on the internet. I will share the link with you. The consensus guidelines we talked about, but some other capacity building initiatives. Our colleagues from WHO start next week with a free course on mental health and psychosocial support in emergencies. 11 sessions of an hour that you can do self-paced, and you can learn a lot about the MHPSS response. And more or less lastly, we are also working on a minimum package of services for mental health. Was in the making for years, but now the Ukraine response is here. We try, as 4 UN agencies, you see on the bottom, to develop a response that includes mental health within the different sectors, from health, education, child protection, GBV response, etc. Very, very lastly, I talked a little bit about the UN. I should have also highlighted the various NGOs. There are many. There is one I want to highlight, the Global Initiative for Psychiatry from Ukraine, an NGO that has been working for decades in Ukraine already and has developed a great network of tools and trainers. So if you want to help, link with such organizations or support them financially. This was actually my last slide. I just want to say it's unprecedented what's happening, but in a way it's not. Remember the refugee and migrant crisis of 2015, when all the Syrians and Iraqis went through Greece and the Balkans to Germany and Sweden. At that time, we made a brief guidance tool with 12 points that you can see here. And actually, in the current response, these 12 points are still, I think, the 12 priorities. So we need also to learn from lessons from the past, use the tools that we have, and then I think we can really make a major difference in the life of people. Thank you very much.
Thank you so much, Pieter. I have a lot of gratitude for all of the wonderful presenters. Thank you all for sharing your expertise with us today. Now I would love to take some of the questions from the audience that have been posted in the Q&A. The first question that I think could be answered by all of our speakers was stating that there are some unique circumstances in this war that make it unclear to me whether certain people would be considered if they were still under stress or not. For example, if someone has been resettled in a neighboring country, but they have family members still at risk in Ukraine, would they be considered under stress or ready for more active interventions? I imagine it would be really hard to engage while the risk is still ongoing for their loved ones.
If you let me, I would comment on that. Definitely, it depends, of course, on the resiliency of those people who are safe now but have relatives under stress. Because some people, because it depends on the premorbid condition and so on. Some people have relatives in relatively safe location, but have really acute stress reactions, panic states, and so on. And I would, of course, make this approach more depending on the resiliency of each individual.
Thank you, Iryna. Marit or Pieter, anything to add to that?
Yeah, if I can, I'm not a clinician these days anymore. These days have passed. But what I would say actually is a bit old-fashioned, perhaps. I would say, are you able to have a strong clinical relationship with your with the person? That's first, and you cannot have that if the person is in a very unstable situation. Secondly, ask the person what their needs are. And if a person says, I just need housing, I need to know where my family is, and there are all those practical issues that the person is concerned about, then I would be very hesitant to actually go into more trauma-focused work. But this is dangerous to say in a webinar with all trauma experts, so you know better.
I would like to add to that it's also, if people would come up with symptoms that are very clearly related to events they have experienced in Ukraine, for instance, or are very depressed, cannot do anything during the day, are very worried, very much ruminating about problems they cannot actually solve at that time, right? I think, on the other hand, it's very important to give people tools to actually solve, to acknowledge that these problems may be unsolvable, but there are daily problems and there are daily activities that still can provide pleasure. So I'm a little bit more optimistic, and I would say that it depends on the person, it depends on the type of problems, the type of concerns, in order to see whether it's possible to do treatment. Because I would also be cautious to say, well, these people have family in Ukraine, they're worried, so we can't do anything, right? Because that can also be sometimes a little bit of a caveat here in a very unstable situation that we don't know how long will still last. Yeah.
Thank you all. Another question that I believe any of our panelists could respond to is, what types of services would you recommend for the humanitarian workers or care providers who are helping with this crisis?
I think, Pieter, would that be a question for you? Because you are in the humanitarian field,
yes.
right?
No, I definitely can. I think it's a great question. I think it's relatively well organized within the major NGOs and with UNHCR. There is, and the UN agencies, there is a duty of care for staff. And so you have to attend to the well-being of your staff. And I won't say it's perfect, but there are systems for that. There are also pre-deployment and post-deployment debriefings, etc. So there are systems. I think the issue here is also the volunteers who work, because much of the work has been done by volunteers, by local professionals who had limited experience in humanitarian settings, but just started to intervene because someone had to help. There we see a major risk for burnout, and actually we already hear some anecdotes, negative anecdotes, that people who started to work and thought, okay, let me do this for a week, starting without knowing when to end, and that after a few weeks people burn out, and in one case even the Polish army had to come in to run a place because people just couldn't cope anymore, but also didn't want to leave. So I think it's important here to have attention for that, and I think it should be one of the targets when NGOs, particularly local NGOs, are going to make proposals. It's part of normal programming that you take care of the people who deliver the services. And that is getting into the system slowly. But certainly, I notice that many local organizations just either don't think about it or are afraid to ask for such services. And I think it should just be part of the normal programming. The other thing is then with low-key interventions, you can still do a lot, which we learn from very low resource settings where we often work, having peer groups, setting up peer systems, like a very simple way that you have, for example, a buddy, that everyone has one person in the team who cares for you, calls you once per week or so, asks you how it's going. These very simple mechanisms can help. I won't say it solves everything, but can help. But it needs to be on the radar of the managers. That's what I would say.
Thank you for that. We have a few questions in the chat directed specifically to Marit with regard to scalable psychosocial interventions for young children or teens, and also interventions that might be applicable to unaccompanied minors.
Yeah, that's a very good question. There is PM Plus is not meant for children or Self-Help Plus. We are currently evaluating it in teenagers, but they're 16 and above, so they're almost adults, right? But really children, there is another program which is called EASE that has been developed, but that's not actually already published by WHO because they're still trialing EASE. And in terms of the evidence, there are so many, there's much less evidence for children interventions, unfortunately. It's KidNet. There's a child version of narrative exposure therapy. And there have been some interventions in school-based interventions. Peter, you can maybe add to what I'm mentioning here.
Yeah, I raised my hand already, as you saw maybe, but continue talking. Now, I just wanted to talk about an intervention that is not so well known, the Common Elements Treatment Approach, CETA, which has been developed by a group at Johns Hopkins, which is cognitive behavioral therapy, but in a modular approach. It's one of the more comprehensive scalable psychological interventions, so to say. It requires quite some training and supervision. So it's one of the more complex ones, but still scalable. And the good thing is that this has been done in Ukraine. So there are trainers and materials in Ukraine, and this can also be done with adolescents. I don't know very young children, but there is evidence for adolescents, if I'm not wrong.
Yeah, I don't think for young children, because I actually...
No, not young children.
Yeah. So for young children, there's certainly a gap, and I think an important gap to fill also by our trauma community to really develop and evaluate interventions. Yeah.
That's a somewhat related question here is for the interventions that you've mentioned, Marie, with Self-Help Plus, PM Plus, CETA. There was a request for links for individuals who are interested in learning and having more resources available. So if it's possible to provide those or link those in the chat, that would be great.
Yes, of course, I can put them in the chat, but there are many links because there's all different versions. There's Ukrainian, Russian, there's the audio files of Self-Help Plus, etc. But I'll try to give a couple of links. We can also put them on the website maybe on the ISTSS research page.
Wonderful, thank you.
Yeah.
Yes, and all of our panelists today so wisely brought up, the situation as broad-reaching, not just focusing on PTSD, and grief being one of the key areas that has perhaps been understudied, underlooked, underappreciated. And one of the questions was specific to interventions under review that are showing evidence for addressing grief reactions. Can any of our panelists speak to that?
I have heard about interventions for military, which is called grief leadership. And I think this approach might be extended toward not just military population, but it's something when, as just mentioned, a kind of a leader or manager or mayor of the city or president might normalize those reactions within the audience or population they're communicating. And this is something that I've heard from a colleague from US, Robert Orsano, who is a military psychiatrist, during his presentation to our colleagues, military psychologists.
I don't know of very specific interventions as such that we can roll out, but I do think why I mentioned grief, and I think Iryna did that as well, I just think it's such a clinically important issue. And I think it's perhaps not just of an intervention to roll out, but to have grief and loss as a central element in the response, also in the clinical interaction, and talk about this. And what we know from other settings, the Rohingya setting in Bangladesh, settings in Africa, is sometimes it can help, maybe not in the acute emergency, but a little bit later, to help people to go through collective bereavement processes and to talk about things they've lost and things they can do actually to cope with losses. And that can be in the form of cultural issues, rituals, religious services, all the things that actually, it's not necessarily a clinical issue. I think communities and people do things by themselves. It's a matter of mental health professionals facilitating that or advocating that it happens. That's what I would want to say about it.
Thank you, Pieter. Iryna, there are a handful of comments or questions for asking for your perspective with regard to Ukraine. One is if there's social media, such as Facebook, currently available. And then also a few questions asking you to help educate us about mental health literacy and perhaps stigma for mental health coping in crises with regard to Ukrainian population specifically for this crisis.
Yeah, of course, Facebook is available. It's translated into Ukrainian, and it plays a really important role right now because, Facebook groups and people immediately enter groups of interests of different matters, and this is really important. This is something that provides networking and communication, and really helps these days. And it's available again. It's no problems. Regarding the stigma and mental health in Ukraine, I would say that it depends on the age, because those who are born in Ukraine, like after 1991, they are have lower challenges with stigma and mental health. I think it's more or less the same as in Europe, probably, or in other parts of the world. But older generation, yeah, the level of stigma is still very high, and the problem is our past, when psychiatry was a weapon from the government to punish people because of their abuse and they're willing to look for some independence. So this is like a part of our history. So those older people, probably they might have more problems with physical complaints and stress-related issues. They would address probably to general practitioners and not mental health providers. Yeah, this something is my impression what happens these days. But I would say that during the acute phase, there is no shame to address problems. I see people very actively looking for help to themselves or for their relatives. There is no shame, no place for shame during these days.
Thank you so much for your perspective. Another question that I would love your thoughts on are how can we partner with organizations to set up programs in countries like the United States where there's a plan and a promise to take in refugees, yet there hasn't necessarily been progress in this area yet. So any thoughts from
well, yeah.
What can be done to prepare?
Yeah, I think it's linking with people who have already developed tools that are appropriate for this specific group. So how can you find them? It's one way to reach them is the ISTSS reference group for MHPSS in emergencies. It's a platform that shares lots of resources in English, but also in Ukrainian and other languages. So I can type that in the chat. No, I can't type it in the chat, but I will make sure you get it. The ISTSS reference group, and that's a good platform. But I'm pretty sure there are others, ISTSS being one of them actually as well. So I think you should link to larger networks and then post your question there. Maybe Ananda, you can answer the question.
Yes, I would love to hear from Marit as well, and I'm happy to contribute thoughts too.
Yeah, it's true. I think what you're saying, Peter, there is this network from this MHPSS network that's currently actually collecting all the requests and all the initiatives taking place within Ukraine, but also with Ukrainian people in the neighboring countries. So, and they also want to make kind of a map of everyone doing that. So they potentially also could link people to specific organizations. So if you would like that, I can also post a link and I can send it to you or to ISTSS to post it later on the resources page. Yeah.
Thank you so much. And there's a question specifically for you, Marit. Has anybody looked at the suitability for skills for psychological recovery for individuals who are past the acute intervention phase?
Sorry, skills? So questionnaires?
Yeah, skills for psychological recovery. And there was a question if anybody has looked at that particular format for individuals who are post-acute phase.
Well, not as far as I know. It's not very, for me, it's not too familiar. I think specifically not in a Ukrainian situation. We're not actually past the acute phase. We're in the acute phase at the moment. So I would be interested to also see these scales or these questionnaires and to look at that, and potentially there is some evidence or some research on that.
Okay, thank you. All right, I'm scrolling through here, seeing if we can address as many as possible in the few moments that we have left. There was a request for more detail on narrative exposure therapy.
On the content of narrative exposure therapy, because actually, well, narrative exposure therapy is a therapy that was originally, but please add to what I'm saying, Peter. It was developed for people with affected by war in African countries. Interestingly, it's also specifically targeted to people who have multiple traumatic events instead of one single traumatic event, which is, of course, often the case, people affected by war. So in terms, it's not necessary, it's not only meant to focus on exposure to one traumatic memory, but people are actually making a lifeline and then are exposing themselves to several traumatic memories or traumatic events they may have experienced, or the hotspots of these memories. And they make this is, I think, a very interesting and also very nice part of this treatment, is that people are really asked to put these events on their lifeline, and also to put stones there that actually indicate an event, and flower when they also have positive events to mention. That puts it also into context. I think that one of the experts on
Exactly.
narrative exposure therapy is in our meeting. I don't know if she's still here, but she could say so much better than I do. That's why I'm also a little bit insecure about it at the moment. But narrative exposure therapy is really a therapy that has also a lot of evidence. And I think we had an ISTSS, or maybe it's an ISTSS keynote lecture also on narrative exposure therapy not long ago.
Yes. Yes, Maggie had put in the Q&A, and I don't know if everybody can see those, so I copied her her response over to the chat, so that she is, she's graciously offered her email for individuals who are interested in more information. Let's see, in our remaining 2 or so minutes, there was a question, I'm scrolling in, can't find the specific language, but with regard to translation into sign language for some of the resources. And a question if that was, if that exists or is a plan that is underway.
I wrote to the person who asked it. I know for sure that people with disabilities are not overlooked in the response. So I know that information materials are being translated in appropriate forms for people with disabilities, including people who cannot hear. But I don't know if these psychological interventions are, that I don't know, I haven't heard of.
Thank you so much.
But the basics, yes, yeah.
Okay. Wonderful, everybody. Well, I would like to take this opportunity to thank our panelists, Arina, Marit, and Pieter, for joining us today and sharing their expertise. I would also like to thank all of the attendees for taking the time today and sharing your comments and questions. And on behalf of ISTSS, I'd like to express my appreciation to the traumatic stress community for their continued work on behalf of those impacted by trauma in Ukraine and around the world. And this concludes today's webinar. Thank you for joining.
Thank you.
Thank you.
Thank you for inviting us. Thank you.